Thanks to Professor Dayasagar Rao for giving me an opportunity to present in this forum, and thanks to Professor Vijayban, the president of the CSI, my colleague Dr. Nagmini and Narayani. I'm sharing with you the experience we have in Narayana, how exactly we proceed, and uh, if there are any doubts, please put it up in the chat box, or you can interrupt me at any point in time. So let's start here. Okay. So pulmonary embolism, all of us know, is a life-threatening condition, and mortality rate is as high as 65%. So the need of the hour is rapid diagnosis followed by rapid treatment. Most of the patients die within the very first hour of presentation. So your timeline to get the investigations, get the diagnosis right, and initiate treatment is very, very limited. Remember that in 60 minutes, you have to make a life difference to the life of these patients. So most of the time, survival depends on how soon you diagnose and initiate treatment. It is the pulmonary thromboembolism is the result of pulmonary artery obstruction by thrombus formed in the deep veins. We've already seen that in Narayani's patient. So this has already been discussed. Just for the benefit of postgraduates, the symptoms are dyspnea, chest pain, palpitation, dizziness, and syncope. We know that our patient had breathlessness as well as syncope. Signs are tachycardia, tachypnea, RV strain, and parasternal heave. Many times when you see this patient, because there is a profound pressure on the right ventricle. JVP was raised in Narayani's patient, 5 centimeter JVP elevation, loud S2, and the pulsatile liver can also be found. ECG findings, we've discussed this. Sinus tachycardia, anterior precordial T-wave inversion, S1, Q3, T3, and precordial ST segment elevation can be there in some patients. Echo, right heart dilatation, RARV dilatation, septal shift, McConnell strength, all this was discussed. And of course, imaging findings, the Hampton hum, which we see, which is representative of a pulmonary infarct, and the Westermarck sign, prominent pulmonary artery with decreased peripheral vasculature, and of course deep vein thrombosis when you see the venous Doppler study. So what are the guideline recommendations for diagnosis in a patient with acute pulmonary embolism? Plasma D dimer, of course, this again depends on in the timeline in which you've seen the patient and the accuracy of diagnosis. Class 1A recommendation, VQ scan, I think one of the somebody put it in the chat box, it carries a 1A recommendation. Venous Doppler assessment is a 1A recommendation. Echo is 1C, emergency CT pulmonary angio 1C, and a VQ SPECT analysis is a 2B level of evidence B recommendation, because this is oftentimes not available in many centers, and of course you need time to interpret the same. An MR angiogram is not really necessary unless you're done with all the other tests and still you find that there is not much clarity on the investigation. So that is a 3A recommendation. Now, as I mentioned, you have 60 minutes to decide on the diagnosis as well as treatment. So why is this timeline so important? Because the moment there is increased RV afterload, there's RV dilatation, there is increased RV wall tension, RV oxygen demand steeply rises, and there is RV ischemia, hypoxic injury, decrease in RV function. We saw that on the echo, decreased RV output. So the patient goes into acute right ventricular failure. And this is where, if you're initiating mechanical support, you need to do it now. And of course, when there is right ventricular decreased oxygen delivery, this patient goes into a right ventricle shutdown. The right heart shuts down, and then this goes into a complete spiral of obstructive shock, and finally the patient succumbs. So all this happens within an hour. So you need to initiate treatment very, very soon. Now, classification, we already spoke about this. You have patients who are low risk, intermediate risk, and high risk. So low risk are the normotensive, low risk as per the PESI score, we'll just come to that in a minute, and the SPESI, and normal biomarkers. These carry a mortality rate of less than 1%. Dr. Nagmani mentioned that these patients can be sent home. Intermediate risk, you need to use your judgment. These are PESI class 3 to 4, SPESI more than 1, echo or CT evidence of RV strain, positive troponin, elevated BNP, and or the NT-proBNP. So here the mortality rate is 5 to 15%. So you use your judgment as to see who stays at home and who should be treated in the hospital with admission. The high-risk patients are the ones where the mortality rate is 25 to 65 patients. all your energy should be to identify these patients early and initiate treatment. Those who have a blood pressure less than 90, Narayani had mentioned that the blood pressure in our index patient is 80 millimeters of mercury. So this is a high risk patient who qualifies for immediate treatment thrombolysis for more than 15 minutes, or a drop in systolic blood pressure of more than 40, or those who are on vasopressors. Other important things that were discussed is there may be a thrombus in transit, which you see in the IVC. The patient can have a syncope or a cardiac arrest. So if any one of these are there, if you see our index patient that we just discussed, BP less than 90 and also syncope, so this patient is a high risk patient and qualifies for immediate thrombolysis and of course support as the time pans out. This is the PESI score which Dr. Narmani had asked, that is Pulmonary Embolism Severity Index. So various factors are seen and accordingly score is given. I'm not getting into this detail. So you classify them as very low, low, intermediate, high, and very high. So the intermediate category gets in from the 86 to 105, high from 106 to 125, and very high more than 126. So these are the patients where you need to have a greater amount of in-depth assessment of these patients, and possibly they may require admission depending on the other features of presentation. You also have a simplified score. It's way too complex. The PESI, you have to take in multiple parameters. As I told you, you have 60 minutes to decide. So getting into all those details may be difficult. So an SPECI makes it fast. So here you have age more than 80 years, cancer, chronic cardiopulmonary disease, pulse more than 110, systolic BP less than 100, and arterial saturation less than 90. Pretty simple. Each of these carries a score of 1. So low means 0, high is more than 1. If you have high, then of course put in the other factors together and then decide. If your pulmonary embolism patient has hypotension or shock on arrival, don't worry about any scores or anything. These are high risk patients and they need to be treated immediately. The one thing that is peculiar is the American Heart Association does not use SPECI or SPECI. So what we are talking about is the ESC guidelines. Patients are classified as massive, submassive, or low risk depending on whether they have hypotension, RV dysfunction, and of course the levels of the cardiac biomarkers. You also have other scores like the Geneva score and then the HESTIA criteria to decide who stays in the OPD, the Wells criteria, and of course there is something called as PERC. So this is a single positive criteria qualifies as a result. Now supposing a patient comes into the ER, emergency room, what do? Does this patient have pulmonary embolism or not? So a patient age more than 50, pulse rate more than 100, pulse ox less than 95, unilateral leg swelling, hemoptysis, surgery or trauma. So if you put all these to our patient had most of these. So this obviously means that you should have a high index of suspicion that this patient is likely to have pulmonary embolism. Then classification of pulmonary embolism based on early mortality risk. You have patients who are classified as high, intermediate, intermediate high, and intermediate low. So what is the meaning of all this? So if they have hemodynamic instability, RV dysfunction, and elevated troponin levels, you see a plus in all of these, and this is marked red. This is a high risk patient likely to die if you don't commence treatment. So these are patients immediately you need to initiate treatment. Now intermediate high, again in the intermediate category, they don't have hemodynamic instability, but they have the other parameters like they have pulmonary embolism severity, comorbidity, PESI score of 3 to 5, or a SPECI of more than 1, RV dysfunction, and raised biomarkers. So intermediate high also stays in the hospital. Remember that. Intermediate low are the ones who have only the PESI 3 to 5 or an SPECI of more than 1, and they one or none positive, that is RV dysfunction or elevated troponin level. These you have to use your judgment. Maybe you can admit in the ward. Sending them home may be dicey because they may be in the process of developing more clots and likely to succumb. So keep them in your ward. Low are the ones marked out in green. They don't have any of these features. You can treat them on outpatient basis. Very, very important to know this chart because this forms the basis of how you decide the treatment and how soon you should initiate treatment. Now, the guidelines are very clear. Who is the patient who is high risk? Patient who's had cardiac arrest, obstructive shock, systolic BP less than 90, or end organ hypoperfusion, or the patient also having systolic blood pressure less than 90 or a drop of more than 40. So these are your high-risk patients, and these need to be treated immediately. Initiate the entire team. There should be a surgical standby, there should be an ECMO standby, there should be possibly mechanical circulatory support available. All this should be necessary because your clock is ticking away and these patients are likely to die immediately unless you initiate proper treatment. Risk adjusted management, we have already discussed this in our patient. High risk, you need to thrombolize immediately. Intermediate high versus intermediate low, I discussed the Narayani, that you need to perform the troponin test, and if the troponin is positive, you have to you can treat on OPD basis. So thrombolytic therapy dissolves thrombus by converting plasminogen to plasmin. With early resolution, you will see that we saw that in our follow-up echo that immediately the RV function starts getting better, the pulmonary artery pressure comes down. So all this means that your thrombolysis has been successful. High risk pulmonary thromboembolism is the clearest indication for this therapy, whereas in intermediate risk, you have to use your judgment and individualize who needs it. And we have a pulmonary thromboembolism response team. I just told you, starting from the perfusionist, ECMO technician, all of them are available, and you should take these patients into the hybrid lab where you may require catheter lysis, catheter-assisted thrombolysis, suction of the clot, and the patient should be able to be taken to the OT immediately and surgical embolectomy if all this fails. So this much should be available when you deal with high-risk patients. So here again, coming into what we just discussed, approved thrombolytic patients, thrombolytic agents are streptokinase, urokinase, and alteplase. Our patient had received tenecteplase. Commonly used, Nagmani had mentioned this, that the commonest used agent is alteplase, short infusion time, 2 hours with a rapid effect. Unapproved agents are tenecteplase and reteplase. Of course, unapproved meaning that as data collects, these will soon be approved. The active resolution of thrombus via thrombolytic agents rapidly improves pulmonary perfusion, hemodynamic effect, the gas exchange, and RV dysfunction. So the patient rapidly improves once you thrombolyze the patient. Indications: high massive pulmonary embolism. Possible indications are intermediate. We discussed this: presence of severe hypoxia or worsening RV dysfunction. As you're watching, the patient is decompensating, or a free floating thrombus. All of these are indications for thrombolysis in acute pulmonary embolism. You can see this. So this is one of our patients that we saw. When you have clots like this, what do you do? So yes, you thrombolyze this patient, and also the surgeon should be on standby. If these embolize, the patient is likely to have an arrest. You should be ready to open up and manually evacuate these clots. Contraindications, very important to remember what are the contraindications. Prior intracranial hemorrhage, known structural cerebral vascular lesion, let's say the patient has an aneurysm, malignant intracranial neoplasm, or active bleeding. All of these are definite absolute contraindications for thrombolysis. And relative are if the patient has severe uncontrolled hypertension, major surgery less than 3 weeks before, recent internal bleeding, non-compressible vascular punctures, let's say patient has AV fistula, patient is a CKD patient. Pregnancy is also mentioned as a relative contraindication. We'll come to that in just a minute. Elderly patients, diabetic retinopathy, and so on. So all of these, obviously, you need to use your judgment. First, the patient has to stay alive, and then we deal with the complications. So depending on how the patient has presented, you need to use your clinical judgment whether he deserves thrombolysis or you want to withhold. This also we had discussed what are the various thrombolytic doses and contraindications Dr. Nagmani had mentioned. The RTPA 100 milligram over 2 hours, 0.6 milligram over per kg over 15 minutes, maximum dose of 50 milligrams. You have 6 regimes of RTPA available. For convenience, I've just put 2. This is what is mentioned in the EAC guidelines. Streptokinase 250,000 international units as loading dose over 30 minutes, followed by 1 lakh international units over 12 to 24 hours. So this is the guideline recommendation. You also have an accelerated regime, 1.5 million international units over 2 hours. So all of these are the guideline recommendation available. Also, the urokinase 4,400 international units as loading dose over 10 minutes, followed by 4,400 international units per kg per hour over 12 to 24 hours. Accelerated regime is 3 million international units over 2 hours. So these are guideline approved dosages for thrombolytics. So dosage and route, all this we've already discussed. Streptokinase, urokinase, altiplase, retiplase, tenecplase. So this is the guideline recommendation, how much you give, when to give, what is the loading dose, infusion, admin time. As we've already said, altiplase, no, you don't even need to give a subsequent dose. Just immediate bolus is enough. So these are very, very useful in patients who have come with massive pulmonary embolism who need immediate attention. Now, guideline recommendation, systemic thrombolytic therapy for high-risk patient carries a class 1 level of evidence B indication. So, rescue thrombolytic therapy is recommended for patients with hemodynamic deterioration or on anticoagulation treatment. 1B recommendation. Now, routine use of primary systemic thrombolysis not recommended in patients with intermediate or low risk B. So many times I've had our referral team telling us that, see, the patient has an intermediate load of thrombus, but let's thrombolyze this patient so that it is efficacious, we can clear up the clot. No, it's never done, because in these patients the risk of the thrombolysis far outweighs the benefit. So it should not be done. If the patient has an internal or an intracranial vein likely to die, and so you should be very, very careful in deciding who doesn't need thrombolysis. Further, the percutaneous catheter-directed treatment should be considered for patients with high-risk pulmonary embolism in whom thrombolysis is contraindicated or failed. In the chat box, somebody had asked if the thrombolysis failed, can we use another agent? As per the guidelines, there is no recommendation for one more agent. However, catheter-directed treatment carries a class 2A level of evidence C recommendation, and also a multidisciplinary team. As I told you, we have a team that's ready at the moment the pulmonary embolism patient arrives. We have a team that is ready, including the perfusionist and the ECMO team, and then the surgeon on standby, and so on. This is very important because your timeline to salvage the patient is just 1 hour. 2A level of evidence C recommendation. Now, this is the hereditary or acquired hypercoagulable state. You have hereditary factors and acquired factors. We've already discussed this. Important is the protein C, protein S deficiency, sickle cell anemia, beta thalassemia. All of these, if the patient has this, preferably should be on anticoagulation lifelong, possibly should be on vitamin K antagonists. Also, the acquired conditions, some of these are modifiable, and so you should take the decision accordingly. So in our institute, we involve the hematologist in the decision making, so that you have a more concrete opinion as to how to proceed in each particular patient. Recommendations for IVC filter also discussed. IVC filter should be considered in patients with acute PE who has an absolute contraindication to anticoagulation. 2A level of evidence C recommendation. It also should be considered in case of recurrent pulmonary embolism despite therapeutic anticoagulation. So in these patients also, it's a 2A level of evidence C recommendation. And routine use of IVC filters is not recommended. So it's a class 3 recommendation. Don't use it for each and every patient. Catheter-directed thrombolysis, intraclot administration, supposed to be more effective than systemic. Rapidly, the drug is washed out and into the non-occluded arteries and may partly reach the obstructive area. So you are able to maneuver through the clots and get into the distal tree. Administration of local thrombolysis can be performed with conventional catheter-directed thrombolysis with a multi-hole and side hole. So you are able to give the clot through, you are able to give the lightning through multiple areas. And pharmacomechanical thrombolysis is, I already spoke about this, combination of catheter-directed thrombolysis with actual suction technique. So this is also very helpful in patients who have high clot burden. So interventional pulmonary embolism, the devices, these are the various approved devices that are available currently, the Echosonic, Unifuse, Crack, McNamara. The one that I highlighted is the Indigo system, which I will show you the case that we did. This is for mechanical clot engagement with mechanized aspiration. Mechanized meaning you just have to keep it there and switch on the suction, and the suction is so good that it can suck out the entire thrombus. So you will see in a reservoir, the aspirated thrombus collects. So this way, large amounts of thrombus can be aspirated out. So this is our patient. You can see that the right upper lobe pulmonary artery is occluded, and also you have clots in the left pulmonary artery. So in the middle, you can see this is the Indigo CP blue catheter that we use for this particular patient. So this is you can, it has two ports. One is you can suck out the clot, and through the side port you can also give the lytic agent. In this particular patient, this patient had an intracranial bleed and also a subsequent verbal surgery that was only 2 weeks before. So no lytic was given. We just aspirated out multiple clots. He presented with a saturation of 74, and after we sucked out the clot, the saturation improved to 96, and he's doing very well on follow-up. Now, subsequently, we also found in this same patient, when we did the venous Doppler, we found that he had a huge amount of clot burden in the popliteal veins and in the deep veins of the legs. So the panel on the right shows that we placed a temporary IVC filter. I kept this IVC filter in this patient for 14 days. Remember that if you place an IVC filter, you need to take it out. 14 days is your timeline, because after that it gets fibrosed and it gets very, very difficult to remove the IVC filter. So at 14 days, this IVC filter was removed in this particular patient. By that time, when we repeated the venous Doppler, we found that significantly the clots had dissolved, and this patient is doing well on follow-up. Ultrasound assisted thrombolysis. This is also available. This is the echosonic. You have a catheter which is placed with a guide wire, and this is the ultrasonic wave. It is very similar to the IVL that we use in our pulmonary intervention. So you can see that this gives ultrasound waves, and this is useful to break the fibrin. You can see that there is disruption of fibrin, and also there's you can give the drug also, and so there is clot lysis, and then you can aspirate it out with a reservoir. So ultrasound assisted thrombolysis is for large clot burden patients. Now, another important thing is half-dose thrombolysis. I think Dr. Armani had already discussed this. So in those patients who have submassive pulmonary embolism, there is a study that was published by Kaiser et al. So the dosage, apart from the normal multiplace of 100 milligram, here the dosage is 50 milligram. If you see the statistics, in hospital mortality in acute massive giving 100 milligrams of antiplase was 21 versus 12 in the half dose, and also the readmission was 8.2 versus 6.4. However, if you see that those who have received half dose thrombolysis, you definitely need to escalate care. It's not enough to just give a half thrombolysis. You need to follow up these patients. And also, if you do propensity matching, the results are fairly comparable. So no big advantage in giving half-dose thrombolysis, except the fact that your immediate crisis in terms of bleeds are reduced. But as I mentioned, the downside to that is you'll have to follow up with further care of this patient and follow up the clot burden. And this is the guideline recommendation for RV failure. Volume optimization, you have to give Ringer's lactate or continuous volume loading saline, less than 500 ml over 1530 minutes, about 15 to 30 minutes. And vasopressors and inotropes, norepinephrine and dopamine are the recommendations. Mechanical circulatory support, a VA ECMO, is the guideline recommendation. And also there was earlier thrombolysis for the deep vein thrombosis also. It's reasonable to consider for those with life-threatening DVT. Of course, I must say that we haven't really done thrombolysis for just deep vein thrombosis, but it is this is what is mentioned in the American Society of Hematology 2020 guidelines for management of venous thrombolysis, indicated in selected young patients at low risk of bleeding for symptomatic DVT involving the iliac and femoral veins, who are at very high risk of even losing the limb. In those patients, you may want to consider this. Of course, this would be a team decision. Patients in these categories who value rapid resolution of symptoms are averse to the possibility of PTS and accept the added risk of major bleeding and may prefer thrombolysis. Use of thrombolysis should be weighed according to the patient's requirement. Complications, bleeding, allergic reactions, intracranial hemorrhage, major hemorrhage, massive bleeding, and so on. All of these are known to us. Mechanical circulatory support, very important for those who have RV dysfunction. I've shown you two panels. One is just an RV support. Here we are using an RV mechanical support in the panel on the left, whereas in the panel on the right we are using the ECMO support with an oxygenator added. You can see in the last in the last image. So the panel on the left shows just a pump, a mechanical pump, which is drawing blood from the jugular through the protective catheter, and it pumps it back so that this takes over the failing RV function. Very, very important, so as to maintain the circulation. Whereas in the panel on the right, you see that there is an oxygenator also available, so that if there is not adequate oxygenation happening in this patient, this comes in very handy, and you can sustain this patient while the clot lysis is in progress. Of course, you also use the Centrimag RVAS, right ventricular support. So Centrimag is approved for use for 28 days. Again, it's a veno-venous protective connection that we use here, and you can see that there's a free floating impeller, so you can sustain those who have prolonged RV dysfunction 28 days or close to a month after a very, very massive embolism. You can use the Centrimag device. Now the panel on the right shows a very interesting thing. We evolved this system of a percutaneous ECMO, that is a VA ECMO. So what we do is we do a septal puncture. You can see septal puncture here, and then this is a peripheral balloon to dilate the septum, atrial septum, and then through this we go up even higher with a peripheral large peripheral balloon, and you see a 24 French cannula entering into the left atrium. You can see that. So, and then this is to draw in blood, so there is oxygenation happening to this patient, and this patient is connected to a peripheral pump, and this will provide the VA ECMO. This can be done in the cath lab by a cardiologist. You don't need a surgeon, you don't need a surgical cut down of the stomach. Last up, Dr. Nagmani had mentioned acute pulmonary embolism, patient surgeon standby. So you can see that my surgeon is cutting the pulmonary artery. You can see the large, massive pulmonary embolism here, and here you can see this is what you're dealing with. So now you know there is no way that this patient can sustain an adequate ventricular flow. You can see that this is the massive embolism that's coming. So just treating them with warfarin or other smaller lytics is not going to help. You need to actually manually, and obviously since there's no right ventricle, the whole pulmonary artery is full of knots. So you need to surgically evacuate this, and our surgeons are very experienced to immediately take the patient on cardiopulmonary bypass and manually remove the clots. So this is a summary of the talk that I just given. Anticoagulation with unfractionated heparin, 1C recommendation, systemic thrombolytic therapy, 1B, surgical pulmonary embolectomy, 1C, where thrombolysis is contraindicated or has failed. Only then the surgeon comes in. Percutaneous catheter-directed treatment, 2A level of evidence C recommendation, norepinephrine or lobotomy, 2A of level of evidence C. That is, this is the guideline recommendation for RV dysfunction. ECMO, 2B level of evidence C recommendation. Initiation of anticoagulation while diagnostic workup is in progress. 1C recommendation. IVC filter, we discussed this in detail. 2A level of evidence C in those where anticoagulation is contraindicated, only in these patients. And of course, multidisciplinary team that we have, not necessary, but if you can get it through, then it's a 2A level of evidence C recommendation. Some quick takes as we complete this talk. So if a patient with pregnancy presents with acute pulmonary embolism, what would you do? Would you thrombolize or you won't thrombolize? So this is the study that is published that even though there is a high risk of fetal or maternal bleed, fetal-maternal death, retrogenicity and placental abrasion, all these should be mentioned in detail to the patient, and written consent should be taken, because there can be two deaths, both the mother and the fetus. So this should be mentioned, and after consent is taken in writing, because this is a legal requirement, can end up in a medical legal case. So you can thrombolize after you've taken consent of this. And how the author has put it is that this Mohammed Alomani is the person who has written about this, and he said that the patient is dying anyway, so you have to take consent, and you have a fair chance of salvaging both mother and fetus. Next is malignancy with acute pulmonary embolism. Cancer patients presenting with acute pulmonary embolism, severe hypotension. Obviously, the benefits of thrombolysis far outweighs the bleeding risk, but again, a written consent is mandatory. This benefit should be clearly explained. This is a wonderful study done by Vida et al., published in Journal of Thrombosis and Thrombolysis. So the conclusion here again is malignancy with acute pulmonary embolism. You have to thrombolyze this patient after taking a written consent. Last is post cardiac arrest. Patient has had a massive pulmonary embolism and you have a cardiac arrest. So while you're doing CPR, should you give thrombolysis or no? Again, the answer is administering a thrombolytic agent during CPR in B is associated with a marked survival benefit. It's an extensive, excellent study done by Botiger et al. So many times we are so focused on CPR, we forget to thrombolyze this patient, and we also fear that since we've done a cardiac massage, there's likely to be tamponade because of giving the thrombolytic and so on. So please remember that if you thrombolyze this patient, there is a good chance that you may salvage this patient. Ongoing CPR is not a contraindication to fibrinolysis, despite a higher risk of bleeding. Obviously, you will explain and take consent. And once a fibrinolytic drug is administered, continue CPR for at least 60 to 90 minutes. So 1 to 1.5 hours is the guideline recommendation that you continue CPR. Only then you are likely to make a difference to the patient. That's it. Thank you, everybody. Any questions? I'll be happy to answer.
Thank you, sir.